I mean, the significant portion of the cost associated with Medicaid, and at the end of the day, the IT system that was built to facilitate the implementation of the Affordable Care Act actually is used more by Medicaid recipients than it is by individuals who are qualifying for the qualified health plans through the exchange, the commercial insurance. So if we were to simply hand the responsibility of the exchange back to the federal government, then we would face the choice of, do we hand the responsibility of Medicaid eligibility back to the local units of government? And our view is to do so would increase the total cost for Medicaid administration for taxpayers and do it in an environment where the new system we have, the eligibility system we have that we built for the exchange, processes those applications in a much more timely and efficient fashion than the system that the counties historically have struggled with, which is the WMS system, which I think is around 45 years old. So any computer system 45 years old has its challenges. So I think at the end of the day, even if the state were to decide that it no longer made sense to operate the exchange, in quote unquote, it still would be in the state taxpayer best interest to continue to move forward with the implementation of state takeover, which is in essence really to a great extent mandate relief for local units of government. And I think at the end of the day creates a much more patient-friendly way to access the programs.
I see that we've included $43.2 million increase in the budget to provide financial assistance for individuals who are in the exchange with an income between 138 and 200% poverty, if I'm correct. My concern is that when you cross the threshold and you earn $1 more than 200%, then at that point, all your co-pays and your deductibles jump, right?
So I think what you're referring to is the state share of the, or portion of the state share for what's called the essential plan.
Yes.
And so this is previously known as the basic health plan under federal law, but renamed the essential plan here in New York. But this is a product really just targeted for two populations. One is the individuals who have incomes between 138 and 200% of federal poverty. And then also, as I've mentioned, also targets those immigrants who are here legally in the state of New York but are non-qualifying for Medicaid, who are switching from state-only Medicaid to the essential plan. Those are the individuals. Roughly half of the people are that immigrant group. The other half are those individuals with 138 to 200% of federal poverty. So the vast majority of the cost for those individuals is picked up by the federal government. And it's a very cost-effective program, very low cost sharing. But in the sense of if you now go over 200%, and now where you are you're either one of two places insurance, you're either on the exchange, choosing one of these qualified health plans, or you're in a commercial product, probably through your employer, where the cost sharing can vary. I can say that in case of the exchange, you still have mechanisms in place for those 200% up to 400% to have pretty substantial tax credits designed to cap your premiums as a percent of your total income, and there's other mechanisms for offsetting cost sharing. But there is what's a bit of a cliff effect, meaning that individuals who go $1 above do see an increase, but not as much of an increase as you would have experienced prior to the Affordable Care Act. But I think that is always that issue of how do you have it so that it's a reasonable increase as people's income rises. We're very hopeful the essential plan, one of the populations with the Affordable Care Act most challenged was those with that incomes between 138 and 200. Even with substantial tax credits, still far too many of those folks finding it unaffordable. The essential plan makes it more affordable.
I am very concerned because, as you can appreciate, when you cross that threshold, you lose eligibility for child care, you lose eligibility for this particular program, the Essential Care Program. The increase makes it almost impossible for many people to accept a raise or move out of that category. So I'm very interested in your ideas on how we can address that fiscal cliff, if you will.
Sure. And the way you're thinking about it is a good one in the sense that individuals, families in these circumstances, they're looking at it from a holistic standpoint, not just a program-specific standpoint, which we tend to in government look at it just from the programs that we administer. And I think the issue is that, but I can't say the Affordable Care Act made the situation far better in the sense that it used to be that the minute you were no longer income eligible for Medicaid, it was about as steep of a cliff as one could imagine, because insurance in the individual market, health insurance, commercial insurance, was almost completely unaffordable. Very few people were buying it, and so unless you had something through your employer, you would simply go without. And so the ACA has made that, resolved that issue to a great extent. But if you dive in deeper and look at the interplay between the programs, I'm sure you'll still see some cliffs that I think none of us would like to see.
Thank you.
Thank you, Senator.
Thank you, Assemblyman Goodell. Next speaker is Senator Kemp Hannon.
Thank you for hanging in there. I was thinking as I'm looking at you as individuals testifying, at the experts behind you, part of the problem we have in trying to get decent health policy is that we now have to negotiate as a finance committee and as a Ways and Means committee with the budget office, which nowhere near has the understanding or comprehension as to what actually occurs when you try to put these things in the field. But I want to just focus on the big numbers. I talked about it before. The capital restructuring program, $1.2 billion that we have not allocated. Brooklyn, $700 million. Oneida, even repurposed, $300 million with the 195 now going scattered to the winds. Transitional funding, behavioral health, $10 million unallocated. Essential healthcare provider monies, $355 million unallocated. And then we have had a fair amount of money in base FAP, behavioral health FAP, VPAP, VB, QUIP. We could have Jeopardy games based on what you know in these things. And we also happen to have an ongoing DASNY restructuring fund that's replenished to the tune of $19 million a year. My whole point is, where are we going with this? What is our vision for this? What is the direction? What will the healthcare system look like when we finish with DSHRM? I was very dismayed to get an invitation to go to a healthcare vision in New York, invitation for February 9th. But it's put on by United Health and the Health Foundation, not by the state of New York, not by the department. Who's doing our visioning? That's the problem. There's been a lot of very good people in your department who really try to help when there are hospitals in need, and there are in need. I talked about the 60 plus that are over the number of days we count they have cash on hand. They still need a structure to go through, and so much of it is still related to Brooklyn. I'm concerned about it as much as anybody, because if that doesn't succeed, the rest of the healthcare system doesn't succeed. I think a couple of months ago, Mr. Helgerson, you were on stage and someone was challenging what you were doing, and you were talking about $100 million a month towards health care in Eastern Brooklyn. I think that was, I'm not making that up, it was a pretty big meeting of hundreds of people. We need to resolve this. We need to be on a path, because we can't keep doing it. How much are we propping up? And even some of the things we're doing upstate, we're propping people up on the little hospitals. Very significant, $4 or $5 million. I think people in those regions would be surprised it goes to be that much. So the other part of it is the vision, supportive housing. It's been there with MRT. It's actually grown. I think there's a $250 million someplace in the budget. I don't know if it's in the health budget. It might be in DHCR. But how is that directly related to health care? How is it indirectly related to health care? Are there going to be qualifications? Are there going to be tests so that we can avoid readmissions by the people we put in the supportive housing? I don't know that there's been enough thought to all of that. Not easy. I once chaired the housing committee. It's actually more complicated than health. A couple of just things that I finish. Naloxone. We've given you the power, Commissioner, to do a standing order. It's not been issued. The Commissioner of the Health for the New York City has issued a standing order. It's available in New York City. I see the other day that CVS says they'll make it available. I presume you gave CVS a standing order. I would urge two things. One, you issue the standing order. And second, we begin a program to have interventions so the kids who get revived 2 or 3 times, we have something to go after them and saying, we want to talk to you. We don't want you to just go home. We want to have referral. We want something that has to be saying to them, no, you can't go on forever, because the history is after a few revivals, they die. And we don't want that to happen. So I urge you about the standing order. Transplants, I must have talked myself blue in the face to you and many members of the administration. That organization that won the RFP still does not have a contract. I would ask for, let's find out where it is. Did it leave DOH legal?
It did.
Is it at ASC? Is it, or AG and or OSC? Let's nail it down and talk to them further. The last thing I have to say is, given the lack of DFS here, and given the major amount of implications, its failures, its non-achievements have resulted in, I'm asking, maybe are you willing to take on regulation of these health plans? Maybe that's what we ought to do and move it from DFS. I mean, you regulate some health plans as it is, the Medicaid managed care plans, so it's not as if this is a new talent you'd have to employ. And maybe we can get it done a lot more efficiently, because at the end of the day, the health plans like Health Republic and the rest in the exchange, and the rest of the health plans who are participating in Medicaid managed care, and the rest of the health plans who are doing commercial health, is very essential to the whole healthcare system. And unless we get this brought a vision also, we're not going to be doing a good service to the people of New York State. I thank you for your patience.
Thank you. Let me respond to a couple of the targeted issues and then the bigger picture. With regards to the organ donation, that is in left DOH. It's with the Office of the State Comptroller, so it's at OSC. Regarding the regulation of health plans, I think it's a bigger question as to where we should be going on that, and perhaps maybe as we move forward and see what happens with the DFS's investigation, we could address that at that point in time. We do have 500 CVS pharmacies have signed on with the naloxone issue. In addition to that, Dwayne Reed and some of the other pharmacies also have partnered with us to work on that, and also independent pharmacies. There are about 1,700, I guess 1,600 independent pharmacies, and we have been working with them as well on this issue. And also, as I mentioned earlier, the possibility of having those pharmacists administer naloxone. But I do hear the concern about if someone goes in, as the Senator mentioned, and they come back out, and then they go back into the system, how do we target that? The housing issue, I'll turn to Jason in a second, but in the bigger picture of where we're going, I hear you, that this is a complex issue of, there's a lot of moving parts on this. There are issues of everything from the hospitals and a transition from hospitals into outpatient care. There are issues of support for the hospitals, particularly whether it's in urban areas or rural areas. There's a lot of challenged facilities out there, and I think part of it is as a result of the fact that we are moving from a hospital-centric kind of care to a outpatient kind of care. And with that comes a lot of challenges that we face. We are moving from a state where there have been 1 in 20 people over 65 to a state that's 1 in 7. So that brings up the whole issues of long-term care, rehab medicine, and even though rehab medicine could be in those younger, but it's something that we have to address in nursing homes. So that is another area. And so we have to step back, and as Senator Kruger said, when you asked me, like, sort of, are you looking at these things? We do. We sit back and we've looked at it, and we actually had a retreat to sort of address this. Where are we going as a state? How are we going to make health care better for everyone? And in a lot of ways, this is where I feel that this is what it is to be in public service, to do what you can to help improve the lives of those in the state. And you raised a lot of issues here, and they all overlap. And that's the challenge, is that these are not in isolation. And as the Assemblyman, the Senator said earlier about not working across agencies, it is important to work across agencies, and also important for us to work within our agency on these issues. I recognize that this is a big challenge, and I do recognize that there's a lot of money going out there. The challenge here is that this is an investment we have to put in there, because if you just keep putting filling up little holes, then you can just continue to fill up little holes. And so I think sometimes you have to just make the big investment. That's what we're looking at. That's what the governor's asked us to do, to just sort of fix it all and make the system better. And it does require a lot of collaboration challenges. But as the Chinese word for like crisis and opportunity are the same, and I guess Assemblyman Gottfried's not here, but I know he's excellent on Chinese characters, but the thing is, that's where we're at. We're at issue of, there are crises there, but there are great opportunities, and I think that we will be able to move this forward. And I do believe that in 5 years from now, we're going to look back and say, we have fixed the system. There was a lot of changes that had to be made, and there's a lot of tough decisions and a lot of unsettling situations, but I think that we'll look back and we'll be pleased about that. District is an example of where we're going, and Jason has been, has shown me some of the things some of the targets of where we've gotten, and I think that'll move things forward too. We're also, as you mentioned, a value-based payment system is something which is really new and novel, and as a result of that, there's a lot of changes that take place. But I am confident that we will get there, and that all New Yorkers will be better for that in the long run. But I hear you, and I recognize that there's a lot of money involved in this. But Jason, did you want to talk about the housing?
Just on the housing, we've been operating the supportive housing program in MRT for, this is going to be our 4th year. I mean, we have very strict definition of what our money can be used for, in the sense of it can be used for capital, it can be used for operational subsidy, it can be used for rent. However, what we say is that in order for a project to receive any funding through MRT, they have to specifically target high-needs Medicaid members, meaning individuals who meet, in essence, the health home definition of eligibility, in order for, and so that whatever the project is, whether it's a new building, whether it's rental subsidies, it has to meet those definitions. So we stuck to that, and but we're not housing experts. We rely on the other state and local agencies across the state to assist us in terms of making sure our dollars are the most effectively used possible. But we have a very clear definition of who we use those funds for. And what we're also doing is in the midst of a very detailed evaluation where we're going to track the results of each and every individual who has a Medicaid program who benefits from our housing. And the reason we're doing that is because we believe at the end of the day it will show that we generate net savings. We want that data so we can prove to the federal government that's exactly what we're doing, and to hopefully get them to agree to match our $100 million a year investment, so we can turn it into $200 million.
And I'd like access to your bookmarks for Salient, okay?
Sounds good.
Okay.
Thank you, Senator. To close, Senator Walter.
Oh, lucky me. No, lucky you guys. All right, so a couple things. The medical marijuana program, how are we doing? Have you seen consistent growth in certified doctors and patients? Do we have any anticipated revenue in the budget? At what level? And then is there anything planned in the budget or going forward to address those who can't afford to access the program?
Sure. So I am very pleased with how the program's going. It is first to mention that we had 18 months to do this. It was the fastest that any medical marijuana program came on board. We started in the beginning of January 6th, January 7th. The dispensaries opened. By the end of this week, we will have probably about 16 of the dispensaries, close to the 20 that we had promised, by the end of January. We have over 350 patients enrolled. We have close to 300 doctors enrolled, and that was, last week, so there may be more as the numbers come in. We've reached out to all the physicians in the state about this, and regarding also for those who can't afford, we have looked at ways, and this works with the dispensaries, of whether there are ways to help to subsidize those who cannot afford this. I think that our program is moving forward nicely, and I'm optimistic to see where it is. I will gladly fill you in as we move forward and give reports back to the legislature on that.
Is there anything in the budget that you've anticipated as far as revenue? Do you know?
Well, we had money that was put in originally, and I'm not sure if where we are on the additional funds for that.
Okay. A couple other topics here. Can you clarify which settlement funds will be used for breast cancer, and are these funds already announced, or is it new settlement money?
So the settlement fund was from Ingenix, and I'd have to get you more details about that.
Okay. Then finally, the governor's office agreed to include the requirement that DOH establish a clinical advisory council with expertise in individuals with disabilities in the 14-15 budget, but DOH hasn't convened this. It says the budget language doesn't require them to. With all of the DOH Medicaid changes, including moving to managed care, and decisions made by DOH that, without consulting with OPWDD, that have negatively impacted those with developmental disabilities, with any disabilities. Would it be a good idea to convene this advisory council to assist and educate DOH staff on the impact to people with disabilities?
So in terms of, it's been a tumultuous couple of years for providers in the OPWDD system, driven to a great extent based on some of the fallout from the financial issues we've had with the federal government relative to the historic way in which providers were paid and the CMS mandate that methodology change. And so we worked very closely with our colleagues at OPWDD as well as with affected providers and other stakeholders to help work through the issues. I know it's created a lot of angst, particularly amongst the providers within that system. In my perfect world, we would not have spent the last 18 months to 2 years, it seems, working on these are really fee-for-service changes, and rather really use this as a time to prepare for the real future, which is managed care, which is value-based payment, which is really trying to give providers more flexibility in terms of how they provide services to this complex population. But we've been sort of stuck because of CMS requirements to negotiate and work to implement this new fee-for-service rate structure. So, what I would say is that we have been in regular contact and consulted on a very regular basis with affected stakeholders in all of this. I hear you about that task force and that committee. We can go back and look into that and see what we can do. But I definitely feel like we have been engaged with the affected parties and understanding that it's created challenges, no question about it.
Well, I mean, if there's an existing advisory board that's there that was promised in the budget language, it would make sense then that you would follow through that process.
Right. I mean, the challenge here is that Carrie Delaney has an advisory group. We have had an advisory group, so there's multiple groups here. But I agree with you. We can look at that language again and see to the extent to which maybe we could consolidate some of those efforts under that one group.
Thank you.
Thank you very much, Senator.
Thank you. I want to thank Commissioner Zucker and Director Helgerson. It's been 4 hours and 12 minutes of testimony, and I think that what that means is that you are among the most popular, sought-after individuals in New York State government. So congratulations on that, and look forward to continuing to work with both of you.
Thank you very much.
Thank you.
Well, yeah, I'll be back, but I've got to do session.
You testify? Christian, this whole thing.